Hello, my name is Brayden Yellman, and today I will be covering Ehlers-Danlos Syndromes more than hypermobility. We have a huge interplay of comorbidities with this collection of illnesses. I understand that some of the previous talks have covered postural orthostatic tachycardia syndrome, dysautonomia as it relates to Ehlers-Danlos, so I'm trying to cover some of the additional potential comorbidities today. I have no disclosures, and I work with the Bateman Horne Center, which is a nonprofit center of excellence dedicated to furthering clinical care research and patient and provider education regarding MECFS, post-acute sequelae of COVID-19, and related comorbidities, some of which include connective tissue disorders like Ehlers-Danlos syndrome. So in this talk, I am hoping to explore the relationship of Ehlers-Danlos syndrome to Mast Cell Activation Syndrome, to central nervous system complications, including Cranio-cervical instability and atlantoaxial instability, as well as occult or acquired tethered cord syndrome. We want to look at small fiber polyneuropathy, gastrointestinal dysmotility, vascular abdominal pathologies, which include median arcuate ligament syndrome or MALS, May-Turner's, and Nutcracker syndromes, as well as MECFS itself, myalgic encephalomyelitis chronic fatigue syndrome, and post-acute sequelae of COVID-19. So we're going to jump right in with mast cell activation syndrome, also sometimes known as mast cell activation disorder. Mast cells are a type of white blood cells that patrol most of our connective tissues, as well as our neurological, gastroenterological, dermatological, pulmonary, and other mucosal tissues. Mast cells are traditionally known to be involved in mediating allergic responses and can play a critical role in protection from worm and parasite infections. However, mast cells also act as sensors for environmental and psychological stress. They participate in wound healing, modulate vascular permeability, promote angiogenesis, and participate in the innate and adaptive immune responses. And mast cells can actually regulate T cell responses, even in the absence of antigen presentation, autoimmunity, or inflammation. So when mast cells are activated, they actually release a collection of inflammatory mediators, cytokines, and proteases. And those famous ones are histamine, tryptase, and leukotrienes. Mast cells are normally activated in the presence of a type of antibodies known as IgE antibodies, as well as several other types of immune system triggers. So that's how they generally will work. However, in mast cell activation syndrome, we actually have a pathological accumulation of mast cells in organs and tissues, and sometimes aberrant release of mast cell mediators or inflammatory markers. Mast cells can be activated by IgE-dependent reactions, or in the case of mast cell activation, they commonly respond to non-allergic triggers, usually of extensively diverse foreign substances in the environment, and this is totally independent of IgE. Non-allergic triggered mast cell activation can then lead to secondary inflammatory mediator release, even without the traditional mast cell degranulation that we've come to know. Activated mast cells can also send distress signals throughout the nervous system and the immune system to other areas of the body, different from where they initially encounter a trigger. And this then alerts additional mast cells in those other tissues to activate as well. So if somebody were to have a mast cell reaction in their GI tissue through signal transduction, they could also have mast cells activate in the central nervous system and in other connective tissues. So how is this related to Ehlers-Danlos syndrome? Well, nearly 1 in 3 patients with mast cell activation has been found to have a comorbid diagnosis of at least hypermobile EDS in a sample of almost 38,000 patients diagnosed with either disorder. In another study, we found that 66% of patients who have EDS and who have postural orthostatic tachycardia syndrome also meet symptoms for mast cell activation. So we really think of these sometimes almost as a triad of overlapping illnesses. Here we have another study where we're actually looking at POTS symptoms, and they divided POTS patients into 2 groups, those with POTS alone, as they said, or POTS with atypical symptoms. So symptoms we don't necessarily generally write down in the textbook as being associated with POTS. And in those cases, the patients who had atypical symptoms, when looking at laboratory results, were found to have much higher prostaglandin levels, as well as histamine levels and other markers that we tend to associate with mast cell activation syndrome as compared to those who had POTS alone defined by their clinical symptoms. In that same study, when you look at those who had the abnormal laboratory tests and the elevated histamines and prostaglandins, those POTS patients were more likely to have other comorbid conditions, including migraines, allergies, and gastrointestinal symptoms as compared to patients who didn't have these laboratory abnormalities. Irregular, recurrent, or chronic release of mast cell-mediated cytokines, such as pro-inflammatory molecules, growth factors, and proteases, has been directly linked to hypermobile EDS and hypermobile spectrum disorders, as well as other heritable connective tissue diseases. In one study, families with heritable mutations in genes encoding for elevated tryptase levels, which is one of the proteases released from active mast cells, in that group, 28% of patients were found to have joint hypermobility, which is a rate that is nearly double of that in the general population. And one literature review found a lack of evidence suggesting that mast cell activation syndrome or hypermobile EDS are even distinct clinical entities. Though, of course, in this study, there is a significant overlap in the pool of vague and subjective symptoms that may play a confounding role in how these results are interpreted. So moving on to symptoms, we tend to think of pretty extensive symptomatology with mast cell activation syndrome. And a lot of those we associate with the histamine-based and protease-based symptoms, as well as leukotrienes. So anything from constitutional symptoms with fever, fatigue, chills, and weight loss. We can see sinusitis, tinnitus, hearing loss, dysgeusia, sore throat, very significant headaches, brain fog, insomnia, chest discomfort, palpitations, low blood pressure, cough, wheezing, asthma-like symptoms. There are actually quite a few urogenital symptoms that look a lot like interstitial cystitis. We see a myriad of gastrointestinal symptoms from heartburn to dysphagia, dyspepsia, nausea, vomiting, early satiety, bloating, food intolerances, diarrhea. We can sometimes see lymphadenopathy. We will see lots of skin symptoms, including urticaria, flushing, itching, rashes, and even dermatographism on exam. And then people tend to have quite a few myalgias and arthralgias, and maybe even some muscular dystonia associated with mast cell activation syndrome. What are the clinical triggers? And these are just some of the things that people have recognized can be very common triggers for them. Heat, cold, or sudden temperature change, stress, which can be emotional stress, physical stress, including pain, or even environmental stressors like weather changes, pollution, pollen, pet dander around them. Exercise can actually be a trigger. Fatigue can be a trigger. Food and beverages, including alcohol. Many drugs, including, and this is specifically pharmacological drugs, opioids, NSAIDs, antibiotics, local anesthetics are particularly known. Contrast dyes can be a major trigger. Natural odors, chemical odors, perfumes, and scents can be triggers. I once had a mast cell patient tell me that the deodorant I was wearing was actually causing her a flare in my small office. Venoms from insects or other stinging or biting animals. Infections may actually trigger a secondary mast cell response. Mechanical irritation, which is sort of where we get to the idea of dermatographism, but also friction and vibration, as well as even sun or sunlight. And I've seen many people come to me in my former rheumatology life saying, oh, I have photosensitive rashes, I must have lupus. And it turns out they actually have mast cell activation syndrome. So how do we technically diagnose this? What are the diagnostic criteria? Well, first, you have to have episodic symptoms consistent with mast cell mediated release affecting at least 2 or more organ systems, evidenced by the following systems, things like the skin, gastrointestinal tracts, cardiovascular tract, respiratory tract, and nasoocular tract. And we've covered some of those symptoms already. Secondly, we need to see that there is an improvement in these symptoms after treatment with some kind of mediator modulator. So antihistamines like H1 and H2 blockers, histamine receptor antagonists, leukotriene antagonists, or even mast cell stabilizers such as cromolyn sodium or ketotifen. And then third, the diagnostic criteria require evidence of an elevation of a validated urinary or serum marker of mast cell activation. And some of the common laboratory tests we'll see here include total serum tryptase, which is very specific for mast cells, elevated serum histamine, a biopsy of tissue, often GI tissue. So we'll see when people get an EGD done, they may have random biopsies. And if you stain for CD117 cells, you may often find mast cells in those patients. And then 24-hour urine levels of N-methylhistamine, 11 beta-prostaglandin F2 alpha, or leukotriene E4 elevations can also be diagnostic. all of this being said, these urinary and serum markers, while are very specific, are not very sensitive. So you have to catch people right in the middle of a flare of mast cell activation. And in fact, even then, the samples have to be handled in a very special way, often sent to a special lab in order to get a positive result. So the absence of a positive result on this testing does not rule out mast cell activation. And in clinical practice, given the challenges we face, I very often will make a clinical diagnosis based on a response to therapies alone, empiric trials of therapy, with a improvement in clinical symptoms without actually getting confirmatory laboratory testing. How do we manage mast cell activation syndrome? There's a lot of ways. A low histamine diet is certainly one way to start, although I would say that that is something that is difficult to maintain in the long term. I'll have people do that when they're in a particularly bad flare of mast cell activation, but usually they're unable to keep up with that in the long term. Diamine oxidase supplementation can actually reduce histamine in oral intake of foods and medications. H1 blockers like fexofenadine, loratadine, cetirizine, and levocetirizine, as well as H2 blockade, can be helpful in modulating symptoms. We all know Benadryl or diphenhydramine. Leukotriene blockade, particularly montelukast, can really be surprisingly powerful. And then we really like to reach for mast cell stabilizers for reasons that I hope will become more clear as the talk continues. I use both liquid cromolyn or gastrocrom as well as a compounded cromolyn sodium. Sometimes the combination of those two are important, in so much as the liquid cromolyn tends to stay in the GI tract itself but not be systemically absorbed, whereas the systemic compounded cromolyn, when absorbed, can get to other tissues but often cannot have direct GI effects if you don't first dose gastrocrom 15 minutes before the liquid cromolyn. It's almost that you have a mast cell response to the medication itself before it can be absorbed into the bloodstream. We also use compounded ketotifen at doses of 1 milligram twice daily, OTC or over-the-counter flavonoids like luteolin and quercetin. In some instances, when IgE levels are elevated in the serum, we can use omalizumab, and then I sometimes reach for steroids, moderate to low doses of prednisone for acute management, but never really for long-term therapy. So mast cell activation syndrome is associated with all kinds of other different illnesses, including chronic inflammatory response syndrome, fibromyalgia, Ehlers-Danlos, as previously mentioned, Gulf War illness, interstitial cystitis, irritable bowel syndrome, Kunis syndrome, which is a cardiovascular syndrome where there is coronary vasospasm and sometimes even under acute stress, a Takotsubo cardiomyopathy. Multiple chemical sensitivity syndrome, MECFS, post-Lyme syndromes, which in many cases may actually be MECFS, postural orthostatic tachycardia syndrome, and even PTSD. And it's also associated with very specific pain syndromes, prostatitis, endometriosis, interstitial cystitis. We mentioned fibromyalgia already, neuropathic pain, post-operative elevated pain, irritable bowel syndrome, vulvodynia, and even self-injurious behavior, interestingly enough. So this is not meant to be an extensive review, but merely to point out that triggers for mast cell degranulation can be extensive and often hard to determine. We like to think that there's always some easily identifiable allergen for a trigger of mast cell activation, and that is not always the case in clinical practice. There are also triggers of mast cells that don't require degranulation. And as you can see here, there's all kinds of additional potential triggers, many of which are inflammatory cytokines from other aspects of the immune system being activated. So I'd like to really hammer home that mast cell activation is not just histamine release, leukotriene release, and tryptase release. Those are the most common symptoms. Those are the easiest to detect in clinical practice, but there really is a lot more to an activated mast cell. And this right here is just a beginning list to show all the different mediators that are released from mast cells. And so you can probably appreciate that the response to mast cell activation is extensive and has all kinds of different downstream pathophysiologies, again, that are maybe not as obvious as histamine with rashes, for example, but are still quite relevant in the pathophysiology of this illness. Mast cells in different tissues are also phenotypically different, and they can have different activating triggers in different tissues. They can have different membrane receptor expression and different patterns of cytokine or chemokine release in different tissues. Specifically looking at hypermobile spectrum disorders and HEDS, mast cells are thought to produce inflammatory changes in these connective tissues that then affect multiple organ systems. And one review paper suggested some of the following complications here. So when mast cells are localized to peripheral nerve epineurium, perineurium, and endoneurium, they can release mediators that may activate nociceptive symptoms such as peripheral neuropathy, headache, and small fiber polyneuropathy. Mast cell cytokines can lead to dysfunctional fibroblast proliferation in the nasal and bronchial tissue, which is associated with rhinitis and sinusitis, and even chronic destruction of the sinuses. Many of my patients have had multiple nasal reconstructive surgeries. Mast cell-induced TGF-beta upregulation in the bronchial smooth muscle can modify matrix proteins of bronchial parenchyma and contribute to tissue damage and asthma. TGF-beta upregulation in the esophageal tissue can cause proliferation of smooth muscle and smooth muscle contraction. That can lead to things like dysphonia, dysphagia globus, and even eosinophilic esophagitis. Mast cells in local connective tissue can also cause microenvironmental changes in the extracellular matrix, including IgE-mediated autoreactivity. And it's been postulated that this may actually play a role in the development of several rheumatological conditions. We also see that there is laxity of the blood vessels with pooling of blood in the extremities in patients with HEDS that we believe is related to mast cell cytokine release. And so we see that in patients with dysautonomia, POTS, MECFS, and long COVID, in addition to just those with mast cell activation alone. Mast cells can also be found in the brain, particularly in the hypothalamus, thalamus, third ventricle, pituitary gland, and pineal gland. And in mast cell activation, these mast cells are often notably activated and affected by things like emotional stress, and it's thought to be via the effects of corticotropin-releasing hormone. Mast cells also appear to regulate the permeability of the blood-brain barrier and may be involved in neuroinflammation and brain disorders. So again, neuroinflammation has been implicated in illnesses like MECFS, post-acute sequelae of COVID, and even autism. Activated mast cell mediators, such as histamine and tryptase, can then activate microglial cells in the brain. So if you have activated mast cells, they then start a cascade of activating microglial cells, which then act as a part of the innate immune system and release their own pro-inflammatory mediators, including IL-1 beta, IL-6, and tumor necrosis factor. Microglial cell activation and neuroinflammation has been implicated in triggering multiple brain disorders, as we said, MECFS, PASC, autism, etc. And here, I just wanted to touch on the connections between mast cell activation syndrome and COVID-19 infection as well. So mast cells are actually thought to serve as hosts for SARS-CoV-2 by expressing the ACE2 receptor, an important receptor for this virus upon host cells. And upon stimulation by SARS-CoV-2, these mast cells rapidly secrete preformed granules as well as inflammatory cytokines and chemokines, and they tend to release these within 6 to 24 hours of the virus binding that ACE2 receptor. Here we have some spiderweb plots that show mean mast cell mediator release symptom scores, and I would direct your attention to the right side of the screen where we have patients with mast cell activation and then patients who are post-initial acute COVID-19 infection. You can see the symptomatology there is very similar as compared to those before COVID-19 infection or general population controls. And we bring this up because vasoactive mediators from mast cells allow these cells to infiltrate multiple organs, including crossing into the blood-brain barrier, which we think could be the beginning or trigger for long COVID or PASC when patients are initially infected with COVID-19. And we have also seen in several small studies that pharmacotherapy that's used for mast cell-related disorders has actually been found to be effective in reducing both the severity of the acute viral illness caused by SARS-CoV-2, as well as reducing the incidence of post-acute sequelae of COVID-19 or long COVID when we take these during acute infection. So in other words, if you take antihistamines, if you take mast cell stabilizers, if you take leukotriene antagonist during acute infection, there is a lower risk of developing post-acute sequelae of COVID, and there is a reduction in the severity and the duration of the acute viral illness as well. This is just a simple reminder to say that if you have a patient with clear mast cell mediator release and mast cell related symptoms, and their symptoms do not wax and wane, their symptoms are not improving with the therapies that we've already outlined, do not forget that there is a set of abnormal mast cell proliferation disorders that include cutaneous mastocytosis, systemic mastocytosis, mast cell leukemia, mast cell sarcoma, and mastocytosis associated with other hematological neoplasias. So keep that in mind if things are not quite adding up for just mast cell activation in the patient that you're taking care of. There could be a neoplasm. All right, now we're going to move on to some of the neurological and spinal manifestations that have been noted in EDS syndromes. So there, of course, is incompetent connective tissue, and we think that that may result in laxity of ligaments within the axial skeleton, peripheral nerve sheaths, and even the architecture of the myoneural and muscular end plates. Neurological manifestations may arise from associated weakness of the ligaments of the cranio-cervical junction and the spine, from early disc degeneration, and from weakness of the epineurium and perineurium surrounding peripheral nerves. Ligamentous laxity in particular leads to nerve structure entrapment, deformation, and biophysical deformative stresses. And it's thought that these stresses may then contribute to secondary altered gene expression, cellular function, neuronal function, and even phenotypic expression. So this is a list of many of the neurological and spinal manifestations that have been recorded in EDS syndromes: headache, migraine, idiopathic intracranial hypertension, Chiari-1 malformations, spinal kyphosis, dystonias, Tarlov cyst syndrome, abnormal neuromuscular features, which include myalgia, nocturnal muscle cramping, progressive muscle weakness, hypotonia, poorly developed muscles, and scapular winging. But I do want to focus today specifically on three that tend to be very clinically relevant in my clinical practice, which are cranio-cervical instability, atlantoaxial instability, and acquired or acute tethered cord syndromes. So starting out with cranio-cervical instability or atlantoaxial instability, this is a manifestation of incompetence or hyperlaxity of ligaments and bony elements supporting the cervical spine and the cranio-cervical junction, which is where the skull sits C0 on C1 or when C1 sits on C2. And this leads to increased motion at these sites. And while cranio-cervical instability traditionally is thought to arise from things like neck trauma, abnormalities in expression, structure, and function of the fibrillar collagen can actually lead to this ligamentous incompetence or hyperlaxity and lead to increased mobility at these joints as well. And it's postulated that collagen or ligamentous incompetence may also be triggered by or accelerated by inflammation related to mast cell activation, although we are still in the active process of investigating this and it does need some more research. Clinically, it appears that when we control mast cell activation, that some of the issues related to CCI actually slow down or even resolve. So we see increased mobility and instability that can then precipitate deformation of the brainstem or the upper spinal cord, which includes the ventral brainstem being compressed or basilar invagination. We can also see increased mobility and instability that can create traction on the vertebral artery or alter venous or cerebrospinal fluid outflow tract from the cranium, causing pressure headaches or other complications. And there is now increasing recognition of the formation of axon retraction balls or axon retraction bulbs as a result of stretching or deformative stress injury upon neurons. And so in CCI, we see findings similar to those in diffuse axonal injury of the brain, where stretching of the neurons causes pathological calcium influx and then a secondary altered gene expression or even apoptosis. Cervical medullary syndrome is another term that's used to sort of describe the constellation of symptoms we may see in a cranio-cervical instability or atlantoaxial instability case. This can include headaches, cervical neck pain, double vision, dizziness or syncope, vertigo, memory loss, tinnitus, dysphagia, dysphonia or speech difficulties, altered vision, numbness and paresthesias in the arms or legs, weakness in the arms or legs, choking or aspirating on food, emesis, frequent awakening, especially when trying to sleep, snoring, sleep apnea, ataxia or gait changes, altered sexual function, or altered menses. So how do we make a diagnosis of CCI? And this is something that's sort of evolving in the field right now. There is certainly an imaging component that we're going to get to, but there is also an important functional assessment here. So one of the things we'll do is give people a prolonged trial of upright cervical stabilization using a collar, either a hard cervical collar. These are all sort of secondary utilizations for these collars. They were designed for other purposes, and we're using them off-label here. But the idea there is to actually hold the head up for an individual. And I'd point you to the center of the screen here to remind you that as the neck gets flexed forward, the weight of the head can actually press, versus much, much heavier in the cervical spine, and can actually press down into the area of the brainstem, causing some of that neurological irritation. So the idea of upright cervical stabilization is to sort of hold the head up against gravity and prevent that progression of neurological irritation in the course of a day. And if people were to wear cervical stabilization collar and notice that after a prolonged trial of that when upright during the day that they had a reduction in incidence of symptoms, that might indicate underlying CCI. We also do trials of upright cervical traction. I often will use here in the bottom left corner an Aspen Vista multipost device. Over here we have a Minerva cervical collar. There are other off-the-shelf collars that we can use as well. And the idea here is to actually create a neutral position traction without flexion of the neck or extension of the neck, which would exacerbate CCI, to try to almost slip things back into a neutral anatomical place and relieve symptoms. And in fact, there's even something that certain patients have been benefiting from called deep water traction, where they'll wear a flotation device around their neck and put ankle weights on to sort of create traction at the neck. And it's interesting, even when we don't see as much exterior anatomical translocation as we might with our other cervical collars, there seems to be something about floating in water that helps the traction be more effective for symptom release. And I don't know if it's that the neurological tissue is almost floating within the canals there and creating sort of an internal traction. We're not quite sure what that is, but it's becoming a really interesting tool to look at. In traction, we're looking for improvement of symptoms, particularly things like headaches, brain fog, fatigue, vertigo, nausea, GI motility, gait or balance or coordination. Extremity weakness may improve, dysphagia, dysarthria, or even sensory sensitivity. These are all things that can improve when people are actively in traction, and sometimes even when they remove the collar for a period of time before things sort of settle back into place. However, traction may trigger symptoms as well. So sometimes we see that people have increased nausea, increased headaches, muscle spasm or dystonia, particularly in the cervical musculature. I think there is quite a bit of recognized almost adaptive or compensatory tightening of the musculature in the neck and shoulder girdle when people are unstable, almost reflexively to protect against that instability and neurological irritation. And then, of course, in our post-viral illness population, we can see post-exertional malaise as a result of traction as well. Just touching on the nausea part of things, it almost seems like for some people that the anatomical translocation we see with traction almost rubs up or pushes right on that nausea center, so that can be very hard to overcome. Important to point out that traction can also elucidate occult symptoms of tethered cord syndrome, and we're going to come to that in a second, but these could include urinary symptoms, low back pain, lower extremity weakness or pain, gait disturbance, or inability to lay down without flexing at the hip and knees. And so the idea there is that if you have tethering of the base of your spinal cord, you have a downward pulling force, and now you're creating upward pulling traction, you're going to get elucidation of those tethered cord symptoms. So that, even though that's not an intended goal, if you think of traction as a diagnostic measure, it's certainly helpful in elucidating the presence of tethered cord and its clinical relevance to a patient's condition. When it comes to imaging, upright imaging is always considered better than supine imaging, and sometimes necessary, because the effect of gravity upon unstable anatomy is key to the identification of cranio-cervical instability. In an ideal world, we use dynamic flexion and extension views as well, because these are critical to identifying pathological anatomy based upon specific positioning. Imaging centers are often unfamiliar with the imaging protocols and correct positioning we need in order to get the correct type of imaging to make this diagnosis. And very few radiologists or neurosurgeons are actually trained in appropriate evaluation for these conditions. So this is an area where we absolutely have room for growth. I have submitted imaging to neurosurgeons at various institutions, good institutions, and those neurosurgeons pound their fists on the table and say there is no cranio-cervical instability here. And they're looking at supine imaging, they're thinking about CCI in the context of Down syndrome, of long-term damage from rheumatoid arthritis, from a traumatic injury, and they're not thinking of a dynamic CCI in this particular population. And when we go to a neurosurgical specialist who is someone who does this day in and day out, they look at the imaging and they say, look, this is what I see. There's absolute CCI here. Are they seeing something nobody else is? It doesn't seem to be, because when they perform surgeries or do other interventions, patients improve. So I think we have a lot of room to learn and get better at our imaging protocols and how to identify CCI based on imaging. So right now, in an ideal world, we would get upright brain and C-spine MRI with flexion and extension. I know in my own personal practice, I struggle to get good upright images, and so I tend to lean towards the second best thing, which is a 3 Tesla MRI brain and of the cervical spine MRI with flexion and extension views. That's in the supine position. It's not perfect, but often is good. We also try to get upright cone beam CT or rotational CT scans of the cervical spine with flexion and extension views. That's particularly helpful in identifying atlantoaxial instability. 3 Tesla MR angiograms and MR venograms of the head and neck can be really helpful. We talked about how there can be impingement of the vertebral arteries, of the jugular veins, of cerebrospinal fluid outflow that are relevant, especially when you're thinking about potentially having this patient evaluated by neurosurgery. And then we will do additional screening for tethered cord syndrome as well, which I'll come to. Important to point out that formal ophthalmological exam to rule out papilledema and idiopathic increased intracranial pressure is also quite important, even though that's not part of this kind of traditional imaging complex. So what do we do for management and treatment of CCI? Also quite an evolving field. This is changing every day, but we like to start with conservative management because surgery is always a last resort option. It's a significant surgery with many risks. So one particular physical therapy protocol that's recommended is the Muldowney physical therapy protocol, and we like to supplement that with specialized PT from a hypermobility expert. So really the idea behind the protocol is build up strength starting in the glutes and the core, work your way ascending up the back into the extremities and eventually into the cervical spine and lower extremities. This is because if you just strengthen one area like the neck, people tend to then have an area of weakness just below it and have disc herniations or other injuries in other weak places. So building an entire scaffolding of strength seems to be critical to avoiding injury and allowing particularly specialized strengthening like of the deep cervical musculature to be effective in the long term. As we mentioned, we do upright cervical traction and support, and sometimes that traction, when it provides immediate relief of symptoms, can be supplemented with PT, and we actually see patients improve. They start to hold themselves in a new anatomical position that relieves their symptoms, and we don't have to do all that much on an interventional basis. We also like to avoid exacerbating factors, so muscle relaxants, Botox, which is sometimes given for headaches, can actually weaken the cervical musculature, which may be stabilizing in the case of CCI, and that could actually lead to more motion and more exacerbation of the underlying neurological issues. However, when these conservative measures are not enough, we do indeed consider a surgical fusion. Of course, you want to take into account what a patient's function is, but if they're severely limited and have low quality of life and understand what the risks and benefits are, I do think there is a role for surgery here. It is complex and has many risks, and postoperative care can be challenging. Patients are left with a lack of cervical mobility, which can be somewhat disabling to a few of them. And there are a lot of complications, including CSF leaks or fistulas, infection, vertebral artery damage, hardware failure, other vertebral instability, worsening of bowel or bladder function via actual exacerbation of a comorbid tethered cord situation. So it's a big deal, but for some people, surgical fusion absolutely relieves symptoms. And I do want to point out that when we talk about an MECFS or long COVID, one of these post-viral syndromes, that entire symptom complex is not cured by surgery for CCI, which is a misnomer that's out there. That's something that's been spread before. However, cervical fusion can essentially relieve many of the exacerbators of dysautonomia in those conditions, which can seem like enormous clinical benefit. People can feel 80 to 85%, 90% better after a cervical fusion. They still have some of the underlying metabolic deficiencies. They still have some of the underlying dysfunction of the innate and adaptive immune systems. They can still have aspects of dysautonomia, but those things tend to be much easier to manage clinically, pharmacologically, et cetera, after a spinal fusion than before. So it's an enormous positive impact when it does work, but it's not the same thing as a cure. There are other treatments for CCI that are out there that are touted, but there's a lack of peer-reviewed data for things like regenerative therapy. So I just wanted to touch on them because they are out there. People have had them done and sworn by them. My patients have not done very well with these therapies, and I think we just have a lot more to learn. There may be value in these things, but right now the data is not supportive of that, and we need more peer-reviewed data. So that includes things like prolotherapy, platelet-rich plasma, and posterior stem cell therapy or percutaneous implantation in the CCJ ligaments, or what we call PICL. So that's an autologous stem cell injections into the anterior posterior ligaments that are thought to promote tissue integrity and tightening and stability for CCI patients. So again, maybe this will come up in the future, but we are not there yet. All right, acquired or occult tethered cord syndrome is often found in conjunction with CCI, although not always in a 1-to-1 ratio. This is an anatomical restriction of the normal movement of the spinal cord via the filum terminale, with tightening or tethering being the abnormality. A healthy filum is a fibrous, collagenous, and elastic bond that connects the conus medullaris to the dural sac at the S2 level. However, the filum in this case appears to be morphologically altered with fatty tissue, dysplastic axons or nerve twigs, fat, and vascular lacunae, or even congested veins. And so the pathology in this condition is thought to be from forcible flexion stretching of the spinal cord against the filum, which actually causes tissue damage and repair, inflammation, potentially mast cell activation inflammation as well, and or altered gene expression at the levels of the tethering. So what are the symptoms of tethered cord? Well, there's a classic triad that includes neurogenic bladder, lower extremity weakness or sensory loss, and central lower back pain. But it's actually a little more complicated than that. We can see unsteady gait, loss of lower extremity sensation, migratory pains in the lower extremities, often positional, urinary frequency and urgency, frequent urinary tract infection-like symptoms, dysuria, urinary retention, gastrointestinal problems or dysfunction, lower back pain, pulling sensations in the brain, upper spine, or even in the sacral area, depending on if you are flexing or extending at the neck or if you're flexing or extending at the hips. Toe walking or an inability to heel walk is something that when you really try to elucidate the history, you'll be surprised to find, or you'll be surprised to see on physical exam, and also frequent suboccipital pain and pressure as well. So HEDS patients frequently present with symptoms of tethered cord syndrome without the traditional finding of a low-lying conus medullaris. Morphological and biomechanical testing of the filum terminale in 78 HEDS patients indicated limited elastic properties, exposing the conus medullaris to non-physiological stretch forces. And this is a finding that compared 38 cases of low-lying conus tethered cord in patients that did not have HEDS. So these situations are actually different. HEDS patients may benefit from the filum terminale being excised or cut, even in the absence of a radiographic low-lying conus medullaris. So how do we get a diagnosis of tethered cord? Urodynamic testing can be invaluable to evaluate for neurogenic bladder manifestations. Somatosensory and motor evoked potentials are an invaluable tool as well, but it's very hard to get that here in the United States. We see that way more in our European colleagues. and then 3 Tesla prone supine lumbar spine MRI under a very specific protocol that's not done at most imaging centers can be very revealing as well. So the idea behind this is that you can get, sometimes you can see the fatty streaks in the filum terminale, but other times you can see that when you flip from the prone to supine position that there is a lack of motion of the conus medullaris, and if it was untethered you would see that move with gravity. And this is a reminder here that normal supine MRIs are not adequate for evaluation of tethered cord. So if someone comes in with a normal L-spine MRI, it's not 3T, it's not prone and supine, it's not going to help us in this case. How do we treat tethered cord? Surgical detethering is a viable option for those presenting with moderate to severe symptoms and radiographic findings. However, in some cases, we can actually see retethering over time. We don't know if that's due to continued abnormal forces from a concurrent presence of CCI or atlantoaxial instability. We don't know if that's from mast cell activation at the site of healing or some other kind of inflammation. And there are cases now where a surgical Gore-Tex-like material is placed after a tethered cord release to help prevent retethering. It's important to point out the filum terminale could actually be part of the sensory motor system involved in spinal alignment, sensing non-physiological stretch forces from excessive spinal movements. So as such, the filum terminale could be acting as a stabilizer in cases of CCI or atlantoaxial instability. So when you detether, you can actually expose or exacerbate existing cranio-cervical instability, but can also allow for improved clinical response to cervical traction. So while some people may have more motion and exacerbation of their CCI symptoms if present, we also find others who maybe were not responsive to conservative cervical traction measures may now actually respond to traction much more easily with much more notable symptomatic improvement with minor degrees of traction. So moving on to some other neurological manifestations, I wanted to touch on small fiber polyneuropathy. And this is a reminder that small fiber nerves are small unmyelinated sensory afferent C fibers and thinly myelinated A delta fibers. They can also include postganglionic sympathetic autonomic axons. And these nerves are small diameter fibers that innervate most organs and tissues. Remember, an EMG or a nerve conduction study are not sensitive for the detection of small fiber polyneuropathy, and instead the gold standard for diagnosis is a punch biopsy, where they actually look at the density of epidermal nerve fibers in the skin. And a loss of density is consistent with small fiber polyneuropathy in this evaluation. Here we have a study where there was quantitative sensory testing performed on 79 HEDS patients with anamnestic complaints, and we found that 70% of those patients actually met criteria for small fiber polyneuropathy. Those patients, many of them at least, also underwent a skin biopsy to evaluate for intraepidermal nerve fiber density, which is our gold standard for diagnosis. And so that was performed on 69 of those original 79 same patients, and it was found that 78% of those 69 patients actually met criteria for small fiber polyneuropathy as well. So the clear relationship here between small fiber polyneuropathy presence and HEDS. I thought this was interesting. So the small fiber polyneuropathy diagnosis in these HEDS patients was considered definite when both the QST and the intraepidermal nerve fiber density criteria were met. And that was actually noticed in 58% of those patients, but then there was an additional 33% of patients that met one of the two diagnostic criteria, leaving only 9% of the HEDS patients that were studied here without a signal that suggested small fiber polyneuropathy. And here we have a heat map of the areas of sensory symptoms in HEDS patients. This is kind of a composite of all the patients in the study, and here we have the 9% that had no small fiber polyneuropathy. This is the group of people, 33% that met one of the two diagnostic criteria, and then these are the patients with definite small fiber polyneuropathy, and there's a pretty interesting match in the heat map of symptoms between the general population and those with definite small fiber polyneuropathy as well that I found fascinating. Remember that small fiber polyneuropathy is not just sensory symptoms. We can get loss of axon innervation of myovascular structures with our small fiber polyneuropathies as well, which is going to affect dysautonomia symptoms. And loss of myovascular innervation can result in vessel patency that leads to things like arteriovenous shunting and skipping of capillaries and the related exchange of oxygen, nutrients, and removal of metabolic waste products. Some of the autonomic functions of small fiber nerves include heart rate responses to deep breathing, heart rate and blood pressure response to Valsalva, heart rate and blood pressure response to tilt, the sweat response, and gastrointestinal functions. So remember, the gut is densely innervated by small nerve fibers as well, and the loss of these fibers can result in a wide range of abdominal and digestive symptoms, including GI dysmotility, esophageal dysmotility, gastric dysmotility, postprandial nausea and vomiting, GERD, weight loss, anorexia, cachexia, diarrhea, constipation, and what we tend to refer to as irritable bowel syndrome as well. In regards to gastrointestinal dysmotility, we have one study that evaluated 129 patients referred to a tertiary neurogastroenterology clinic, and 49% of these patients were found to meet criteria for joint hypermobility syndrome. At least that's what they called it there. And there was an unknown etiology for GI symptoms when there was an unknown etiology for GI symptoms in these patients, it was significantly more likely that those patients met the criteria for joint hypermobility syndrome. And 12 of the 17 patients that were found to meet the criteria for joint hypermobility syndrome evaluated were also found to have delayed gastric emptying. In another study of EDS patients at Mayo Clinic, there was noted abnormal gastric emptying observed in 22% of these EDS patients, with 11.8% of these patients having delayed gastric emptying, and actually the other 10.5% having accelerated gastric emptying. It is now common to use wireless motility capsule testing or smart pill testing to evaluate transit time of the gut. And there was a study where this was performed on 20 individuals with idiopathic autonomic neuropathy and unexplained gastrointestinal symptoms in order to evaluate the entire gastrointestinal transit time and contractility. Transit times were predominantly abnormal and delayed in the foregut region, so the stomach and the initial first portion of the small intestine. However, contractility abnormalities were far more prominent in the hindgut and the colon, and that was present in 85% of patients. Detected neuroanatomical overlap between the presence of autonomic reflex abnormalities and transit time and contractility abnormalities was absolutely present in this case. So what do we do for dysmotility treatments? Pyridostigmine is sometimes used. Prucalopride or Motegrity, when you can get insurance coverage for it, is sometimes helpful. I personally use a lot of metoclopramide in my practice because it's easily accessible. I know there's a black box warning on that here in the United States, but when used at doses of 2.5 to 5 milligrams, maybe only in the morning, occasionally sometimes before dinner as a second dose, I have not run into any extrapyramidal symptoms despite keeping people on this for years, and it's often sufficiently effective for notable symptomatic benefit. In some particular GI clinics, they are now doing pyloric sphincter Botox and myotomies when this is relevant, and there is the opportunity for gastric pacing in some cases as well. I would also argue that treating underlying mast cell activation can help change some of the motility symptoms. In particular, really high activity of mast cell activation tends to lead to diarrhea, even when there isn't theoretically huge increase in gut motility or transit time. And then we also like to treat dysautonomia or orthostatic intolerance aggressively, especially using things like midodrine and droxidopa. I've found that it seems to shunt more arterial blood to the gut, which allows it to function a little better and actually induce a little bit more peristalsis. Median arcuate ligament syndrome or celiac artery compression syndrome is also associated with HEDS or other EDS syndromes. So here we have 11 patients with MALS who underwent a corrective surgery between 2013 and 2018 that were evaluated for other uncommon disorders in a retrospective study. And 7 out of those 11 were found to have delayed gastric emptying. 4 were found to have radiographic abnormalities in the visceral vasculature. 3 had POTS, 2 had EDS. And authors suggested that there's probably a possible pathophysiological relationship. And certainly any of us in clinical practice can say we are always finding MALS, or often finding MALS in our patients. So this is defined by recurrent abdominal pain related to compression of the celiac artery by the median arcuate ligament. Symptoms could be mediated by ischemia or by other neuropathic mechanisms. We're not quite sure. It's characterized by a triad of postprandial abdominal pain, weight loss, and occasionally you may hear an abdominal bruit. It's definitely more common in females, and it generally will present more commonly in the 4th decade of life. Initial imaging is often done with mesenteric duplex ultrasound. Diagnosis is confirmed when we see elevated celiac artery velocities that then normalize with deep inspiration. We will then follow that up with a confirmatory CT angiogram, which can sometimes show a J-hook conformation of the celiac artery. Surgical options for treatment include release of the median arcuate ligament, but patients may also elect to perform neurolysis of the celiac nerve plexus. 70 to 80% of surgical success. There is a 70 to 80% surgical success rate in reducing abdominal pain, though continued abdominal symptoms may be representative of one of the other functional gastrointestinal complications that we've covered today or others that we haven't covered. May-Turner's is another venous congestion syndrome that we may see with HEDS or other ADS syndromes. It's defined by the extrinsic venous compression by the arterial system against bony structures in the iliocaval venous territory, which is most commonly the left common iliac vein compressed by the right common iliac artery. Partial obstruction can often be asymptomatic, but progression over time can actually lead to formation of deep venous thrombosis. There is an estimated prevalence of 2 to 5% of patients in general, and it's more common in females presenting in the 2nd to 3rd decade of life. Symptomatic patients may present with extremity pain, swelling, venous claudication, or signs of venous insufficiency, particularly in the left lower extremity. Diagnostic considerations for May-Turner's include a CT or MR venography, but the gold standard is intravascular ultrasound. Sometimes this is conservatively managed with compression stockings for mild symptoms, but more symptomatic patients will commonly be treated with angioplasty and or stenting. There could also be a requirement for thrombolysis of any clots that exist, and occasionally patients will require post-operative anticoagulation, and that is generally up to the surgical team to determine. Nutcracker syndrome is one other venous congestion syndrome that we see quite often in this population, and it refers to a compression of the left renal vein between the aorta and the proximal superior mesenteric artery. Symptoms include things like hematuria, orthostatic proteinuria, and left-sided flank pain. Diagnosis is suspected when there is a CT or MRI showing intrarenal and perirenal varices, enhancement of the left gonadal vein collateral, and diagnosis is then confirmed with Doppler ultrasound showing left renal vein compression or elevated flow velocities. Treatments for nutcrackers can include left renal vein stent placement, transposition of the superior mesenteric artery or left renal vein, or even left kidney auto transplant. And then lastly, I just wanted to touch on myalgic encephalomyelitis or chronic fatigue syndrome, which also generally includes patients with post-acute sequelae of COVID. Many of those patients who've had symptoms for over 6 months meet the criteria for MECFS, and we believe that, in fact, they do have MECFS triggered by the COVID-19 virus. These are the diagnostic criteria for MECFS, and we see these in a much higher degree in our patients with hypermobility. It's almost as if that predisposes to the development of this illness. So as the 2015 IOM criteria go, it requires a substantial functional impairment for greater than 6 months that is often associated with fatigue. It requires post-exertional malaise, which is really our pathognomonic feature of this illness, which is essentially a reduction in physical functional capacity as a result of exceeding a certain amount of energy expenditure, whether that is done through physical exertion, cognitive exertion, or even emotional exertion. There's often a delay in the onset of these symptoms, and we know that this is a condition where there is a true change in the metabolic capacity of patients and a significant exacerbation of many of their multi-system illness symptoms. Unrefreshing sleep is the third criteria. So almost all patients with this illness will have trouble no matter how much they sleep, whether they're sleeping successfully or not successfully. Even when they do sleep well, their sleep is unrefreshing and non-restorative. And as the 2015 IOM criteria defined it, you need to have either a waxing and waning cognitive impairment or orthostatic intolerance. I would say as we continue to treat patients and get better at understanding how to measure these things, it's probably true that all patients have a waxing and waning cognitive impairment, and this is different from a progressive neurological illness where things get continuously worse. The cognitive impairment is often brain fog and attentional deficits, sometimes issues with decision-making and disorientation as well. And then orthostatic intolerance was probably touched on in the earlier lectures regarding POTS and dysautonomia as well. So there's no single sensitive or specific biomarker for the diagnosis of MECFS, which is why the best we have is these IOM criteria. Please keep in mind that these are core clinical criteria that define the illness, but of course there are tons and tons and tons of other comorbid conditions, many of which are the same comorbid conditions that we see in our EDS population that I've covered today. So again, tons of overlap in all of these illnesses. And like I said, post-exertional malaise is really the pathognomonic feature of MECFS and post-acute sequelae of COVID in most cases as well. So with that, I will cut this short and say thank you, and hope that you're all a little more aware of all of these comorbid conditions and can, at the very least, refer back to this lecture if you suspect these in your own patients or your clinical practice. And thank you for your time and attention.